syphilis eyes, the pupils that accommodate but don't react, just like prostitutes. Ha ha ha. So funny. Here's my approach to peripheral neuropathy that you can just read about in your own time. Treatment will essentially depend on the cause. Most of the time, it's going to be caused by diabetes. So if you get a station about peripheral neuropathy, you always need to talk about management of their diabetes above just management of their neuropathy as well. So dementia is very, very, very low yield. I'm just going to zoom through it because it's not important and you don't have to know about it until 4th year. So there's 4 broad types of dementia. There's 4 broad types of dementia. Alzheimer's disease is by far the most common. It's the classic, people usually start off forgetting about things and then it just progressively declines until they just got full-blown cognitive decline. But it starts off with memory. Vascular dementia has onset in relation to stroke, so it's got a very stepwise progression where they get a stroke and they get a little bit of a decline. They get another stroke, it gets worse. They get another stroke, it gets worse. It's very stepwise. Frontotemporal dementia is the exception to the dementias because most dementias usually happen in people over the age of 65. If you're under 65, it's very unlikely that you've got dementia, except for frontotemporal. Frontotemporal tends to happen more in young people as well. Frontotemporal dementia usually starts off with either a personality change or a behavioral change. So they're doing stuff that's just not their usual self. And lastly, Lewy body dementia is a triad of fluctuating cognitive deficit, Parkinson's symptoms, and also hallucination. So if they've got those 3, it's Lewy body. Multiple sclerosis, despite being a blue condition, is actually quite important to know because it gets asked about quite a lot in your exams. Risk factors, basically young women, and also a family history. Clinical features, they'll get a whole bunch of neurological signs, both numbness, like sensory and motor. But the key thing is that most people with multiple sclerosis will present with optic neuritis. And how do you know it's optic neuritis? Because they get visual changes, they get eye pain with movement. And when you do an ophthalmoscopy on them, they get cupped optic discs where the optic disc actually bulges out, okay? It's a hallmark sign of optic neuritis in MS, okay? They might also have what's called a relative afferent pupillary defect or Marcus gum pupil as well. They might, the Monash questions might actually, they won't necessarily say Marcus gum pupil, they might actually describe it, so just don't fall for it. Also, people with multiple sclerosis tend to get their symptoms worse on hot days. So it's a good thing to ask about if you're asking about aggravating factors. So either the end of the day or a hot day. So a young woman with neurological dysfunction and painful eyes, think multiple sclerosis. The clinical sort of like picture is that most people will have what's known as a relapsing remitting. So they get episodes and they go into remission. They get episodes and go into remission. But there's actually 4 different types. And people with relapsing remitting can eventually get into what's known as a secondary progressive, where it just becomes a progressive decline. MS is very, very debilitating. You need to diagnose it quickly. And once you've diagnosed it, you need to get onto the treatment quickly. These guys need some kind of immunosuppression, and then they get symptom relief as well. It's also good if if you're managing patients, to give them a leaflet from MS Australia. This is the nice thing to add in your OSCEs. So this brings up an important point that any condition which isn't just neurological that affects your lung function, you need to do a lung function test as part of your investigations. One of the leading causes, probably the leading cause of death in multiple sclerosis, is because they eventually get paralysis of their diaphragm. So to manage these people, you need to do lung function tests, okay? Parkinson's disease. So Parkinsonism is a clinical syndrome that's categorized by TRAP, your tremor at rest, rigidity, akinesia or bradykinesia, and postural instability. Parkinson's disease is essentially just an idiopathic Parkinsonism. So it's Parkinsonism when we ruled out every single other cause of Parkinsonism, okay? It's caused by a loss of dopamine in your brain, specifically in the substantia nigra. And what that means is that you lose your ability to perform voluntary movements. Causes of Parkinsonism, there's a lot. Remember, Lewy body dementia can also cause Parkinsonism. Wilson's disease, which is when you get like too much copper in your whole body, that can cause Parkinsonism, especially if it's a young person. metoclopramide and antipsychotics can also cause Parkinsonism. So you've got to like really rule out all these other things before you can consider asking them, or you can consider diagnosing them with Parkinson's. Interestingly, a protective factor for Parkinson's is smoking. I guess probably because you'll die of lung cancer before you get Parkinson's. That's just my theory. It's a coarse tremor that usually starts in one limb and then eventually progresses to involve everything else. And you've also got that classic shuffling Parkinson's gait. They might, rather than actually saying that they've got a Parkinson's gait, Monash might actually say, well, they've got like a shuffling small, like a shuffling short gait, or they keep leaning over when they walk or something like that, or they can't change direction easily. Don't fall for it. It's a Parkinson's gait, okay? It's a clinical diagnosis, and it's only a clinical diagnosis because you've got to rule out everything else first, okay? They've got the cardinal symptoms, and you can also trial some levodopa carbidopa to see if their symptoms resolve, because if their symptoms improve with levodopa replacement, chances are it's Parkinson's, okay? And also that there's no red flags suggesting something else. So the mainstay of treatment is always your levodopa carbidopa. Your main side effect from levodopa carbidopa is nausea. If they're nauseous, don't give them metoclopramide, because metoclopramide crosses the blood-brain barrier. Metoclopramide's a dopamine antagonist. Metoclopramide will worsen their Parkinson's, okay? So instead, the drug of choice is domperidone, which is exactly the same as metoclopramide, but it doesn't cross the blood-brain barrier. Over time, Parkinson's is a degenerative condition. Things will get worse as time goes on. Your dose of levodopa will have to increase until you reach the maximum dose and you can't go any higher. After that, you need to start thinking about adding other agents in. You can also treat their psychiatric issues, because a lot of people with Parkinson's will have a depression as well. And if you're really end stage, you can start thinking about surgery. Yeah, I'm just going to move on. So as far as other causes of headaches, you don't really need to know them in any sort of real detail. The only important thing is that you need to just be able to recognize them on history. So tension headaches, stress-related, band around the head. Worse with any stresses, like it's a clinical diagnosis once you've ruled everything out, and management is just management of the headache and then management of the causes of the headache, okay? Cluster headaches, one-sided, really excruciatingly painful, comes on and off like minutes at a time, usually occurs in a whole bunch of times, multiple days in a row, and then it stops for a few months, and then it comes back in clusters. That's why it's called a cluster headache. They're also known as suicide headaches, because a lot of people who get cluster headaches also end up committing suicide. Treatment is usually through oxygen and also triptans, and you can also give them prophylaxis to stop it from coming back. And remember, the way that you differentiate between this and a migraine is that these guys get like teary red eyes and also a runny nose on the side of the headache, which you don't get in a migraine. Trigeminal neuralgia is, well, it's a neuralgia, so it's an electrical sort of sensation, a shooting pain across your face. Most common is the maxillary nerve, and then it's your mandibular, and then it's your ophthalmic. It's caused by an aneurysm in the blood, in the arteries. It's not caused by shingles, okay? Everyone seems to think that trigeminal neuralgia is caused by shingles. That's not trigeminal neuralgia. That's post-herpetic neuralgia. There's a difference. It's also known as a suicide headache because a lot of people also tried to commit suicide. The treatment of choice for trigeminal neuralgia is carbamazepine, okay? That's the specific drug. That's the specific nerve sort of anti-epileptic agent that you use to treat neuropathic pain from trigeminal neuralgia. And lastly, giant cell arteritis is just scalp pain, scalp tenderness, and they get this thing called amaurosis fugax, which is just transient loss of vision in that eye. They can also get jaw claudication, so like pain on chewing, which is another good thing to ask about if someone's got a headache. And the way to diagnose GCA is by doing a temporal artery biopsy. So basically they just literally take the artery out and look at it under the microscope. And if they've got GCA and they've got loss of vision, you just king hit the GCA with an absolute massive dose of prednisolone. Again, benign intracranial hypertension, not something I ever learned about until this year. The classic one is overweight or obese women of childbearing age. And there's a big drug association between idiopathic intracranial hypertension and the drug tetracycline or doxycycline, the antibiotic. It's a bit of like a brain tumory pain because it's raised ICP. headache worse in the morning. They can also have a whole bunch of other signs like tinnitus, visual blurring, vision loss, and double vision as well. So the way that you can actually finally diagnose it is by doing an LP, and it has a high opening pressure. So you actually attach a manometer to the needle as it goes in, and you can actually measure the pressure of the subarachnoid space. So management is mostly through weight loss, change their meds if any of the meds are implicated in it, and the mainstay drug is essentially diuretics. Guillain-Barré is very, very rare. It's also very low yield. Just know that it's often preceded by a viral or bacterial infection, and the classic bacterial infection is Campylobacter jejuni. So if they get bloody diarrhea and they end up all of a sudden with all these nerve dysfunction, it's probably Guillain-Barré. So again, Guillain-Barré has imminent death from respiratory failure. So if you've ever got time in this whole medical emergency, it's worth doing a lung function test. Treatment is mostly through plasma exchange or IVIG, so intravenous immunoglobulin, and you might need to put them on ventilation support because, again, death is from respiratory failure, as is the cause of death in most neurological conditions. Myasthenia gravis, very, very rare, very, very interesting. The kind of people who get affected by it, young women and old men, okay? Myasthenia gravis, young women and old men. Again, death by respiratory failure. So what are we gonna do? We're also gonna do a lung function test on these guys. These guys get muscle weakness that's usually worse at the end of the day, okay? Specifically worse at the end of the day and specifically worse on exertion. Contrast that with a paraneoplastic syndrome called Lambert-Eaton myasthenic syndrome, which improves with activity. So this one gets worse, Lambert-Eaton gets better with activity. They can also get blurred double vision, drooping eyelids, but the difference from MS is that myasthenia is painless, okay? As far as investigations go, you need to do some antibodies, so anti-acetylcholinesterase acetylcholine receptor and also anti-muscle specific kinase. You do some imaging of their chest because a lot of these guys have a very big thymus gland or a thymoma. Even if they have a normal thymus, that doesn't rule out myasthenia. The ultimate gold standard test is what's called the edrophonium test or the tensilon test. You give them a drug called tensilon, and it's an anticholinesterase. And so what happens if their symptoms improved after you've given them tensilon, you've confirmed it, they've got myasthenia gravis. Treatment is immunosuppression and then symptom relief. You need to give the two together. You can't just give symptom relief alone. So symptom relief is essentially you give them pyridostigmine, which is an anticholinesterase, and then you give them atropine as well to stop the muscarinic side effects of pyridostigmine. And just to reinforce, you need the two at the same time to actually achieve a good effect. So motor neuron disease is a bit of an umbrella term, and guess what? It's also very low yield. When people talk about MND, they're usually talking about amyotrophic lateral sclerosis or ALS or Lou Gehrig's disease if you're American. Like I said, it's very low yield, so I'm going to gloss over it. Just know that I've included this condition here at the very bottom, spinal muscular atrophy. That's a pediatric condition, and it's also a motor neuron disease that you'll learn about next year when you do your pediatrics rotation. Don't learn it now. So ALS will give you both upper motor and lower motor neuron signs. The big buzzword is muscle fasciculation. If they get tongue fasciculation, it's usually described as like their tongue looks like a bag of worms because all the muscle fibers are just twitching on their own independently. And the way that you investigate is you got to do some nerve conduction studies. And also, because these guys are going to die from respiratory failure, you got to do a lung function test. So management, how do you manage it? You can't really. There's only been 2 things that have been proven to slow down the decline of motor neuron disease. That is BiPAP and a drug called Riluzole. Okay, those are the only 2 things. If you get diagnosed with ALS, you will die of ALS. Stephen Hawking thought he could outrun it. Turns out he can't run at all. So lastly, myopathy is really not that important. They're essentially just diseases of normal muscle function, and they usually get symmetrical weakness, but they've got normal sensation because it's purely just a weakness of the muscles, okay? There's lots of other causes, but this is a red condition, and we know what our priorities are, so let's just not even bother learning it. The only thing I'll say is that there's 2 conditions under the hereditary myopathies known as Duchenne muscular dystrophy and Becker muscular dystrophy that you'll learn about next year when you're on your pediatrics rotation. Does that mean you learn about it now? No. So that's essentially it. Good job, guys.
Thanks, man. That was really good. Like this.